Today, we're focusing on breast cancer awareness, and we're very fortunate to have with us Ms. Celene Donahue, who brings expertise to this area that's really in the sort of combination area of both medicine and culture. So welcome so much to our program, Ms. Donahue. Really appreciate your being with us.
Thank you.
So Selena, tell us a little bit about your background and how you became interested in public health issues.
Yeah, so a little bit about me. First of all, my name is Celene Donahue. I am Pueblo Indian, and my family is Hoopa, Yurok, and Karuk. I grew up on the Hoopa Reservation in Northern California. My background consists of I worked 17 years in pathology, doing clinical pathology. I worked at UC Davis doing community-based research with 5 Indian health clinics. I worked for a nonprofit at American Cancer Society, and now I'm public health and I do health advocacy. So thank you for having me. That's a little bit about myself.
You've really done quite a lot, and I gather then that you're active in more than one Native American or American Indian tribe.
Yes, so I also chair our California Tribal Comprehensive Cancer Plan program. So I also chair that coalition. I also sit on the Colorectal Cancer Coalition for the state of California as well. So I'm very involved, and for that board, I represent the AIN population. So I'm very involved in the American Indian community.
If I may ask just a simple question, do most American Indians prefer to be called American Indian or Native American?
It depends, so when we're talking about all of us, we usually go American Indian, but it's almost when we're talking amongst ourselves, a lot of times we call ourselves, we are the natives because we are the natives of this land.
Excellent point. And let us begin, if you don't mind, Selena, with discussing first breast cancer in general. Now, I can say as a clinician that it's amazing to me the burden that we bear here in California due to cancer. In at least 22 states, cancer has surpassed heart disease as the #1 cause of death. And that's really interesting because, as I'm sure you're probably aware as a public health researcher, we've actually made great strides in treating both heart disease and cancer, but the heart disease decrease due to statins and high blood pressure medicines and other things has really outstripped the success we've had in decreasing mortality due to cancer, which is kind of amazing because we're also dealing with things like an obesity epidemic that would tend to make heart disease worse. And we can talk about that too if you wish, but the key thing is cancer is so important, and I think it's safe to say that breast cancer is just part of the puzzle. Would you agree with that?
I do. I definitely agree with that. Yeah.
And also, you mentioned colorectal cancer. For example, some of the risk factors overlap, particularly family history and perhaps obesity.
Yep.
Dietary factors, perhaps.
Yep. And especially when we talk, especially for us as Native Americans, when we're talking about obesity and diet, I really always like to talk when I'm doing talking circles or I'm doing an education within our community is going back to our cultural foods as well. So that is an importance because that's how our ancestors were. So if we can incorporate a lot of that into this 2020 life.
I think that advice probably makes sense for all of us. But when we're talking breast cancer, I mentioned that cancer is the #1 cause of death now in California. Breast cancer, I think, for women is really close to the top. At one point, it was lung cancer, but the smoking population from World War II eventually was replaced by a younger population with less of a smoking incidence. And I believe breast cancer is #1 among women now as a cause of death.
Yeah, and like I always say, cancer to us as American Indians is new. No matter what tribe you're from, there is no language in our native language for cancer. So this disease is relatively new to us. So I think it's hard, and also we got to talk about the historical trauma that's involved as well too. So, mixing, a lot of our culture with the Western medicine. So this is new to a lot of this underserved, underdevelopment communities, and especially our Native American communities as well.
Very interesting. And Selena, I think the rate of breast cancer in the population at large is somewhere among women at about 1 in 9. And a lot of people don't realize that about 1% of breast cancers occur in men, probably less than 1%, but at least a small percentage, sometimes associated with other conditions like inherited chromosomal abnormalities like Klinefelter syndrome. But do you have a sense of whether the incidence of breast cancer is higher among Native populations than among the population at large?
It is. We actually just did a talking circle today, and it is our mortality rate is a lot higher than Hispanics and non-whites. And a lot of it is because we're not getting screened, and when we do get screened, it's at a later stage. So that, I think, just really, if we could focus on early detection, screening, and we could lower that mortality rate down for us.
Excellent point. And you mentioned early screening. One of the counties that has a very high incidence of breast cancer in California is Marin County. However, there tends to be, I believe, a disproportionate number of individuals who are fairly affluent with good access to health care who get diagnosed earlier with ductal carcinoma in situ or less aggressive cancers. So the incidence is important, but it's only part of the equation. Also, the question is, how serious are the cancers when they're found to be present? And I'm wondering if among Native Americans, if we tend to see cancers presenting a little bit later due to issues related to poverty and access to health care. Do you have thoughts on that?
I do. I think, again, I think our access to care. So I know where we live, to get screened, the nearest hospital is over an hour away. And then when we talk about the road conditions and wintertime, sometimes that could be an hour and a half away. And even if you are diagnosed and you need to see an oncologist or you need to have a more in-depth surgery, a lot of times they are referred to Sacramento area, San Francisco area, and that could be up to a 6-7 hour drive. So the access to care is a huge barrier.
Now, you mentioned at the outset a couple of tribes. I believe one was the Yurok. I beg your pardon?
The Yurok tribe?
Yurok, yes. Capital Y-O-R-U-K, right?
Yep. Mm-hmm.
Yeah. I have some familiarity with this from having been an anthropologist in another life, but I haven't lived it in the way you have, of course. And I'd just like to ask, when you say where we live, are you referring to a Yurok reservation or another tribe's reservation, or just in general Indian communities?
So my family's from the Hoopa Valley Reservation, and I'm here in Humboldt County.
In Humboldt County, do you have a sense of how many different Native American tribes are represented in the population around you?
Not off the top of my head, but I know there are several tribes around here.
And
so in Northern California and Humboldt County, we have almost 1/3 of California's Native American population.
Really? All in Humboldt County?
All up here in Northern California. So not just Humboldt County, but Northern California.
And so you have the Yurok, did you say the Hoopa?
Yep, we have the Yurok, we have the Hoopa, we have the Karuk. A little bit below us, we have the Kovlos, we have the Wiyot, we have the Bear River Rancheria. So there's a lot of tribes and rancherias that are surrounded by us up here.
And do you find that there's much of a difference between different tribal groups culturally in terms of their feelings about how to deal with cancer or how to approach it? Is there more interaction with healthcare providers? Is there a different experience in different tribes?
I feel like up here, all the healthcare providers, they're all trying to deal with breast cancer and cancer screening all around the same. Access to care, again, is a big barrier for many of the tribes that are up here. So I think the access to care is a huge one.
In some cultures, historically, there has been a tendency to sort of deny the existence of cancer. And there also has been historically, particularly among some older populations, a kind of stigma associated with cancer where people would tend to hide it. Are these obstacles issues that Native Americans confront, or is it culturally quite different in that respect?
It is, I feel like talking, doing a few talking circles and really talking with our elders, talking with our community. Um, it's the fear, it's the not knowing, it's, that support system out there. So those are all big barriers and factors. I don't think necessarily it's that myth of I did something wrong or it's something that happened, but I think it's that the myth out there for a lot of us American Indians is it's the death sentence, which is not necessarily true. But I think that fear of I got cancer, I got breast cancer, now I'm going to die.
I think that's something we have to really fight against in the medical community. We want to really educate in order to empower people and instill hope in them. And in fact, so many breast cancers now are treatable. And in many cases, we see extensive positive results, both in terms of long-term survival or even cure, if one could use that word.
Mm-hmm.
And also plastic surgery for reconstruction and so forth has improved. And of course, there's the whole psychosocial support network of counseling and so forth. Do you find that among the American Indian population that most of the individuals seeking care are primarily English speaking, or are there linguistic obstacles?
Most of them primarily, I would say, are English speaking. But I think what happens a lot is because they go from their Indian health clinic to a local hospital and then get referred out. So a lot of times that information coming back to their primary care provider, navigating them through the system could be a challenge sometimes.
And how hard is it to get an appointment in the American Indian Health Clinic, or I don't know, I forget the precise name for it, the Bureau of Indian Affairs Health Clinic? How hard is it to get in?
That's a very easy appointment to get into, but it's when you have to do the referral outward. So if you're getting referred out to San Francisco or Sacramento, somewhere in those bigger hospitals to do your oncology or to do your treatment, it's getting that referral out and then coming back home to your primary care physician. So I think that communication between, if you're at Stanford, Davis, wherever, coming when the patient comes back home to their rural community and reservation, that's where I think there's a lot of disconnect right there.
You mentioned circles. What is a circle exactly?
So a talking circle is where we actually, that's how we pass down a lot of our knowledge, is sitting around through a circle, talking, passing down education and stories. And so what we've come to do is do a talking circle where we could gather. Of course, now with COVID, we're doing a lot of this stuff virtual, but really getting that information, talking about people's experiences, and then getting that information out to them. What are those risk factors? What are some symptoms? What can you do? What are those barriers? But in a more cultural sensitive way, because that's how we were taught to learn generations from generations.
Now, in performing your work with this population, Celene, do you work as a sort of independent practitioner, activist, scholar, researcher, or do you work primarily through existing organizations? I'm thinking perhaps of the American Cancer Society or other organizations. I know that we've been in touch with them in setting up the show.
Yes, so I partner with American Cancer Society. They're the ones who contacted me. I also work with the California Rural Indian Health Board, and I also do my own contracting as well. So I kind of, I have establishments because I've worked in Indian country for a while. So I've been involved in the public health within a lot of the clinic settings.
Let's talk about some of the other sort of sociocultural economic challenges. I know that Humboldt was devastated by some of the issues that came up when the logging industry really was dramatically downsized 30, 40 years ago. In some ways, I think the economy perhaps did not fully diversify. What's the economy like in Humboldt County, even in the absence of the current pandemic? And then we'll talk about the pandemic.
So for us, this is our home. It's where we've been for a long time, so the Hoopa, Yurok's, Crooks, this has been home. No one's never left. But when we're talking on a medical sense, I know working with a lot of hospitals up here and clinics, it's a struggle economically, especially when you want to get those surgeons and those oncologists up here, because we're not like the big cities that have those department stores and airports with a lot of flights. We do have an airport, but we don't have all those amenities that come with getting a specialty person, a specialty doctor up here. So it's a little more rural, so it's almost harder to find those specialty doctors.
I had the experience of flying into the northwestern part of the state when I was a doctor with the Department of Corrections and part of a team looking at healthcare up in that region at Pelican Bay. And I remember landing on an airplane and being in the fog until the wheels touched down, and it was quite an experience.
Yeah. Yeah.
So let's talk now about the effects of the pandemic. Now, we've already got a situation up where you are, where the economy is sometimes a bit uneven. I can't really speak with any knowledge of the specific challenges of the Native Americans there, but it's more of a rural economy generally. What has the effect been on the Yurok and the Hoopa and the other tribes with this quite devastating pandemic?
So from what I've seen is it's been very it's been hard. So I know, at least speaking, a lot of my family's on the Hoopa reservation, and I know, and I believe the Yurok reservation as well, that during this pandemic they closed their reservations. So there was no access stopping. You could drive through, but because we wanted to protect our elders, protect our children, that we closed the reservations. So that actually, and we actually had a stay at home shelter in place going as well. And I also know to like be able to leave, to those hot spots, they really wanted the community members to stay home and actually go through, the Office of Emergency Services to be able to leave the county to kind of contain what's going on with COVID and everything. So it's had a really huge impact on a lot of the community members up here.
In addition to the talking circles, do you have occasion to travel to clinics, to accompany people in clinics? And what other activities do you do on a day-to-day basis to pursue your passion of helping people with health problems in the American Indian community?
Yeah, so with COVID, I have not been able to travel a lot to other clinics, but prior to that, yes, I really was involved. I actually work with also the California Department of Public Health. I've had calls with them, a lot of the boards, and just really trying to work with the clinics on what can we do to help increase those screenings. What policies can we work with? What evidence-based interventions can we work within your clinic? I've also on a couple boards, we've got some grant fundings that we were also able to offer to several of our Indian health clinics as well.
So let's get back to the issue of breast cancer, which is really the main subject of the show. And let's talk a little bit about screening. What are the attitudes and what are the availability issues relative to mammography in Native American populations in Humboldt County and around there?
Yeah, so again, I think it goes back to access of care. So I know a lot of the clinics up here, they actually been doing a mobile mammography van. So that has really helped, and that actually helps delete the barriers for the access to care. So having the mammo van, the mobile mammo van come up to that clinic. I've also worked with another clinic where, of course, this was pre-COVID, that they would actually make a women's health day, mammogram day, so they would go in there, they would have the mobile mammogram van come, they would have lunch provided, they would have activities such as beading and pillow making. So it was more of a positive thing that was going on, not just so structured where you go into, you put a gown on, you go in, you get your mammography, and then you're done. This was more of like a woman's day for us to come together, because again, culturally, that's how we do things. When we do things, we're doing things together in a group with our family, with our moms, our sisters, our aunties, our cousins. So being able to go and do these things together to get screened together, it also decreases that fear, which is a big barrier as well.
Sounds like you're really doing a lot that's really making a difference on the ground. Now, let us say someone has the misfortune to have a suspicious lesion and to need surgery and referral to surgery and oncology. Is that something that you find can be done locally, or do people tend to travel up to Medford, Oregon, or over to Reading or down to San Francisco? Where do people go?
Yeah, so originally a lot of times they will stay here locally. A lot of times they will not go out of state just because of the medical insurances. Usually it's mostly California based, no matter what that insurance is. But there are several times where they will have to go out to Sacramento, San Francisco, Davis, Stanford. But I know previously, there was like a shortage in oncology doctors up here. I believe that is not the case anymore. So they can do their treatment here, they can do their surgery here, but a lot of times it is sent out for a referral. So there is a process.
I have a nephew who's finishing family practice training in Merced, and he has, believe it or not, something like $500,000 worth of debt from college and medical school combined. And I suggested that he look into working in an underserved community and perhaps even a Native American facility.
Yes.
Historically, doctors used to sometimes accept that kind of a challenge and in return get a little help with their loans. And I don't know if they still do that or not.
I don't know. I'm not sure about that, but I think I've heard of some programs that do offer that. I think you can maybe the California Rural Indian Health Board, they might be able to go through some of that stuff, but there is programs, I believe, out there.
Among the younger generation of Native Americans, do you have a positive feeling about how they're doing in terms of accessing education, going to college, going on to other fields? I know that they're highly, American Indians, Native Americans tend to be statistically quite underrepresented in universities based on some of the data I've looked at. I know that some universities, such as Dartmouth, have it in their mission statement, particularly Dartmouth, to try to attract and educate Native peoples. That's the proper term. Do you think that we're seeing some progress there?
I do. I do. I know I have a lot of nieces and nephews, and I know, and a lot of them have gone to Berkeley and Humboldt State University, and there is a lot of good Native American programs out there. I also have a lot of good friends that are Native American professors out there at Chico and UC Davis, and there is a good programs out there for our Native American students. So I really, again, I know this is about breast, but to get that education, we need more Native doctors and surgeons and oncologists out there, but there is a really good Native American programs at most universities. So I have seen that on the rise versus 20 years ago.
That's kind of what I was getting at, to improve care through culturally sensitive practitioner tools. And of course, that doesn't just involve medicine, it also involves nursing, involves
Mhm.
psychology, social work, and many other fields. Well, as we begin to get towards the end of our time together, Celene, what do you need that could allow you to do an even better job? You're obviously doing a fantastic job helping to increase awareness of both breast cancer and colon cancer among Native American populations. What could society provide or facilitate that would allow you to do even more of your good work?
God, that's a good question. And I really wish I had a lot of my clinic partners on because they are the good ones to answer that questions. But I know it's just resources, and not just any resources, but more culturally sensitive resources out there. Because I know a lot of times we we're not collecting that data that's out there for us as Native Americans. So if we could even, start collecting better data for us as American Indians, and really good resources that are geared towards American Indians.
As we begin to reach the close of our program, I also think it would be appropriate for me to remind our listeners that they could also donate to the American Cancer Society. Perhaps we'll put up their website to remind them of that. And I would really like to extend my deep thanks to the American Cancer Society for putting us in touch with such an excellent guest, both in terms of knowledge of the medical challenges and also the cultural issues, particularly for the underserved population of American Indians. So I'd like to thank both you for your professional work and your assistance and willingness to appear here on Health Focus, and also the American Cancer Society. As we look to the future, do you have a sense that in the next 5-10 years, once we get past this pandemic, that breast cancer screening will pick up again, and that it'll continue to be something where we can make progress, particularly where, as you see it, at the ground level?
I do. And I started, over these past, 5, 8 years, seeing the momentum that was working with a lot of these Indian health clinics on screening. So I think 5 years past this pandemic, I could definitely see us getting back on the ground and running with screening.
And do you have any particular organization that you're involved with that anybody could go to, or any particular website if people want to get in touch with you and try to be of help in this?
Yeah, so definitely contact the American Cancer Society, like you said. And then also another good resource would be the California Rural Indian Health Board. And I will also put that contact information up as well.
Well, we will try to put that information up as well. And in closing, if I could just say, I think probably nothing is more devastating to anyone than a diagnosis of cancer, particularly when it comes out of the blue. And the more that we can do as a society to help people who are struggling with a diagnosis of cancer, the better off we will all be, because it's a diagnosis that really can affect entire families and people of all ages. So in closing, Celene, Donahue, I'd just like to say it's been a great pleasure and honor to have you here on Health Focus to discuss Breast Cancer Awareness Month. Again, thank you to you. Thank you to the American Cancer Society. And hopefully we'll have an opportunity to see you back again someday.
Thank you.
Remember, here on Health Focus, we focus on your health. Today we've been focusing on breast cancer. We hope you'll come back and see us again soon. In the meantime, stay safe and stay healthy. Thanks a lot.